Hello, good afternoon, and everyone, and welcome to the Health and Adult Social Care Scrutiny panel of Tuesday, 7th of December. The meeting is webcast live, and it can be viewed after the meeting has finished as well. I'm Councillor Habiban Zaman, and I'm the chair of the panel. If I can ask the members to introduce themselves. Bill Armour.
Yes, hello, Councillor Bill Armour, Kirkburton Ward.
Leslie.
Yes, Councillor Leslie Warner from Colne Valley Ward.
Dave Rigby.
Yeah, it's Dave Rigby. I'm a co-optee on the panel.
Peter Bradshaw.
Hello, everybody. I'm Peter Bradshaw. I'm an external participant observer and who has been invited. And thank you, Chair, for inviting me again. Thank you.
You're welcome. We also have on the call Liz. Would you like to introduce yourself, Liz?
Councillor Liz Smage. I'm Chair of Scrutiny. Thank you.
You're welcome. We have apologies from Councillor Vivian Lees Hamilton, Councillor Fazila Lunat, and Lynn Keedy. If we can move on to item 1 of the agenda, which is minutes of the previous meeting, can we acknowledge them as a true record? Thank you. Any interest to declare?
I've just got to declare that I'm a non-executive director of the Calderdale and Huddersfield NHS Trust.
Thank you. Item number 3 is admissions of the public. Today we have no admissions of the public. Item 4 is petitions and deputations. We have none at the meeting. Item 5 is public questions. We have no questions from the public today. That takes us on to item 6, which is Care Quality Commission, Quality of Care in Kirklees. And if I can invite Iris, Helen Iris, to present that item to us, please.
Thank you very much. Well, thank you for inviting us to join the committee today. And yeah, as we've understood, we want to be able to give time to questions, etc. So I'm going to kind of glide through these slides, and obviously you can ask questions if you feel there's something that I've missed that you're wanting to ask. So I'm inspection manager for the Kirklees and Wakefield patch for adult social care in the CQC. And I think you'll all be aware of our role and purpose in the CQC. We're the regulator of health and social care services, and we want to make sure that services are safe and fit for purpose for people that deliver high quality outcomes. During the pandemic, our inspection processes were interrupted. We were paused of our inspections for a limited time only. In terms of our routine inspections. So obviously for those that we needed to absolutely urgently get out to, then we still did get out to those. I have to say that there were none that were urgent in that category that were conducted in Kirklees area during that time. But what we very quickly did was we put together an emergency support framework, which meant that in lieu of being able to go and cross the threshold as we would normally, we did have support phone calls with all of the all the services that were registered, and that gave us a picture on how we were assured about how they were managing. And that was something that, although it was not an inspection, it gave us a view on what quality was like, and so enabled us to be able to prioritize what services we should be then getting out and crossing the threshold with when we were able to do that safely with, from our perspective of staff, from the people's perspective, most importantly, you know, the vulnerable people at locations as well, and the staff in the services. At the same time, we were also working on a method to make sure that we were reviewing where there were outbreaks of COVID-19, and we adapted a particular approach to site visits for those inspections where there were over 30% of the people at the location, the residents, being infected with COVID-19, very unfortunately. And what we then did was made sure that we were reviewing all of the aspects of infection prevention in light of the outbreaks. So that was something, you know, that we were doing to make sure that we had a view on quality during, you know, COVID-19. So there's a lot of learning that we've done throughout the COVID-19 crisis, and obviously it's been really important for us to think about, you know, the voice of people, the voice of providers at such a challenging time, and how we share information. And the local systems of sharing information have been, you know, as important as ever. And these aspects of what we're doing to review information in the system, within the system, has actually informed our strategy going forward. And I know you've had a copy of the strategy, our updated strategy from CQC. I know that you'll be interested in these ratings, and what you can see here is that it says post-COVID. We know we're still living in COVID world, but basically these statistics were correct up until the 11th of October this year. So you can see that you know, pre-COVID world was looking, you know, much more reassuring in terms of the ratings themselves, and you can see that the ratings have deteriorated through the pandemic. One of the things that I need to point out in terms of a health warning with that is that we were conducting risk inspections. That's when we picked up, when I said we paused inspections for a very short while, and then we were prioritizing risk inspections, and that is fundamentally what we've been doing since that time, because we needed to be assured that we're getting out to those services that are most risky. So in a way, there's a bit of a health warning about this data, because it does reflect that we were looking at the most concerning of those services. Here is another slide which sort of illustrates again the decline in ratings generally across the patch, and you can see that as the other slide demonstrated, you know, Wakefield is not, you know, it's kind of not as poor as some of the other performers in the West Yorkshire patch. So although the rating decline, so the sort of the levels of it was about 5% there, you can see, in terms of, because pre-COVID, we were looking at 7% of services declining, which increased to 12.3. But you can see that, I mean, Calderdale particularly badly affected throughout the pandemic in terms of the changes. So that gives you some kind of like context there. The next slide that I'm talking to is really just an overview again of the position statement now. Some of these percentages against the national picture, and some of these percentages have changed slightly from the previous information that I shared with you on the graphs, because this information has been pulled off a bit more recently, but it's not that different really. But what you can see is that the requires improvement services are a lot greater than the national, well, you know, sort of significantly greater than the national average, but inadequate round about the same ballpark. Outstanding services, so that we're not as well represented there, and obviously the good rating. So basically this is, we're not performing as well as the national average picture, but it's not a dire picture either. And what you have to remember as well is that you know, the north generally, and particularly in West Yorkshire, we have lots of other challenges that other local authorities don't have. So I think it's important to think about that as well. So the state of health and care report that was published back in October now. This really highlighted the instability across the systems, the problems that we've got all through the systems in terms of staff turnover, and it's very challenging for adult social care because of the fact that it's just such a low status, low paid workforce, and we know that COVID has really exposed and exacerbated those kinds of problems. Funding, obviously early on it was PPE that was a problem. This talks about the NHS because obviously the state of care report is talking about the whole system. And then pre-existing pressures have combined with the COVID pressures. And there's a statement up there about GPs that I know Jill will probably pick up locally. So our strategy, which I've alluded to, you've got a copy of, it's concentrating on 4 main themes, which is that regulation being driven by people's needs and experiences, smarter, more dynamic, flexible regulation that provides up-to-date and high-quality information, and regulating for stronger safety cultures across the systems of health and social care, and enabling health and care support systems to access and support and help to improve quality of care where it's needed most. So this strategy is being implemented over the next 5 years, and it's at the heart of it. There are these core ambitions, which are assessing local systems. So we'll be given extra powers as well, and that is, being reviewed on the statute at the moment. But it is that. So exactly what that'll look like in terms of what it means for us, but it has been through Parliament, so that we will be reviewing the performance of local authorities, tackling inequalities in health and social care. So we will be looking at the equality of access and experience and outcomes from health and social care services by a joined up approach, looking much more flexibly across the systems. Because at the moment, as we're talking to you, we're giving you a presentation in our separate directorates, but going forward, there will be much more fluidity in terms of our inspection approach. There will be a much more centralised approach, because at the moment our approach in adult social care has a slightly different methodology of our inspection to health and to PMS as well, primary medical services, but we're looking to streamline with one assessment tool that leads us with that, and developing our monitoring approach. So I just want to say a very kind of summarised point really about where I started off, about how we were having these supportive calls with all of the providers in the pandemic. We evolved that into an approach which we uploaded information from the provider about how they were performing against different key lines of inquiry that we use on inspection. And basically what we've done is we've evolved that approach further, so that now we are mandated to undertake a certain amount of direct monitoring approach calls. And again, it's not inspection. They don't have an inspection report, but it is about having that conversation with a registered person at the location, and also supporting that further by people's perspectives about care, and then looking and evaluating all that information. So that then helps us be able to understand which inspections we need to be able to prioritise. So that's a bit about how that approach has evolved. And actually what that does then is we produce a public statement by reviewing all the information that we've got about risk in a service. And at the moment, all the public can see. There's a public statement which is published on our website for services where our information does not indicate anything of concern, and that email is also sent to the provider, and that obviously is informed by some of our direct monitoring activity, because where we give them a clean bill of health from a conversation with them and reviewing information, then obviously we are unconcerned about that service in terms of the information that we have. So that's a bit of a whistle stop through there, and it is really quite a whistle stop, because obviously these have been unprecedented times, haven't they? And there's been a lot going on.
Thank you for that presentation, Helen. If I could ask the panel to raise their hands if they have any questions for Helen. Dave, would you like to come in first?
Yes, just a couple of points. I just wonder whether there was any proposal to look at the last 18 months and to do an overall assessment of quality and safety issues as affected by COVID. So looking back at what has happened in relation to quality and safety with a view to learning lessons for the future, either of this pandemic or hopefully not, but maybe a future one. So that's the first question. The second question was, do you have anything particular to say about dentistry? I noticed there's not a section on dentistry, but just given the issues around dentistry currently, whether there were comments you wanted to make on that. Thanks.
I'll go to your second question first, because that's probably the easiest. So I'm a regulator within CQC for adult social care services only, and dentistry doesn't come under my directorate. But you can proffer any questions to Jill in that respect. That's right, isn't it, Jill?
Yes, dentistry does come under the PMS directorate, but I'm not specifically a dental inspector. I'm standing in today for the inspection manager for West Yorkshire, so I can't actually answer any specific questions on dentistry, but we'll be happy to act as a conduit to send those to the appropriate person if that would help. Yeah, sorry, Jill, didn't mean to put you on the spot there, but I didn't know if your presentation might have any stats on. Yeah, but appreciate that you're dentistry, just
GP
practice.
Yeah, appreciate that you're speaking to your speciality of primary medical services. But we can, I don't know if you've got particular things that you want to ask, then we can actually get that information for you.
Okay, I don't have any questions at the moment. Maybe it's something we could pick up at a future session of the CQC where we have the relevant dentistry people to do a presentation on their area of work.
Okay, thank you.
Thank you.
So your first question was about what learning from the pandemic, and obviously our strategy has been evolved through the learning of the pandemic about what's been working, what's been helpful. So our remote approach to the conversations, the supportive conversations that evolved into the emergency support framework, and then now, as I've just described, are part of the direct monitoring approach. That is, that's something that we have evolved through the learning of the pandemic. But there are also various reports that we've written, which are around themes to do with infection prevention. There was a piece around the COVID death data that we published. So there are various, they're called insight reports, and you can actually get hold of them through the website. So I can send you a link to those specific reports. So that information is feeding into our forward approach and thinking. And as I alluded to in my presentation, we're very much the strategy going forward is all about a systems approach, because we recognize that working in silos and not understanding what care looks like in a place is really important, because you might have the most outstanding rated care home, which is absolutely excellent, but if you're being served by a GP practice that is inadequate, then obviously the care is going, and a hospital that is failing in the area, then that is really going to impact on your care outcomes, which won't be recognized by the excellence that's operating only in the care home itself.
Okay, yeah, so a reference to those insight reports would be useful. Thank you.
Yeah, I'll send the link through. Thanks.
Thank you. Councillor Warner, do you want to ask your question?
Yes, thank you, and thank you for your presentation. In what we are overusing the word challenging, I suspect, at the moment. But there were two questions. One was to do with the chart that you shown about the overall rating. And as you yourself suggested, Kirklees was quite a bit higher than other areas in our region. And I'd like what you think is some of the reasons for that, given that you would have thought that there wasn't huge discrepancy between us and Calderdale or Wakefield. And the other question, which must be ongoing all the time, you say it's difficult to improve staff turnover being high. And yet this is ongoing everywhere. And yet it's the crux. All the ideals in the world and all the strategies will never be delivered if you can't retain staff and make the profession something that encourages people to come into it. So I just wondered, in terms of are all the paying conditions offered to current staff, are they within NHS guidelines, and they get paid for travel and they get a reasonable, all the usual things that you would hope were happening? And have you been losing staff as a result of compulsory vaccinations coming in? Obviously, we know we've lost a lot of staff through Brexit. So it sort of really worries me that for all the ideals of what you're attempting to deliver, if you haven't got the people on the ground, that we are not going to be delivering.
Okay, I'll go to your first point, which is, and I brought the slides up here again. So the first slide I'd started with, so you're talking about the kind of poor performance really after the pandemic, or post, well, as we are now from pre-pandemic times. And you can see that in this slide, I mean, Kirklees aren't doing too badly in terms of the inadequate ratings. I know that, I have oversight over the Wakefield patch, and I can tell you that, the activity is a lot more frantic over that side at the moment than it is in Kirklees in terms of quality standards. So, we are at that time when this information was pulled off, it was 1.1, in terms of percentage of inadequate reports across the patch. You got Wakefield at 5.1. Obviously, what is kind of concerning is, clearly the other ratings. So we've got requires improvement at 23.9, but it's only really gone up, by a matter of 1%. And you can see that the good has been impacted, but only like 2%, and obviously the outstanding services have not been impacted there, and that's probably, it's because we haven't found any further outstanding services at the time of this at the time I pulled this report off. But actually it's been skewed by the fact that we haven't, as I've said, we haven't been inspecting for for the routine. So it meant that we've been focusing very much on risk. So that's why the figures are more skewed. So if you look at that, it's sort of not such a bad picture for the patch. And obviously here again, in terms of the decline, you can see that Kirklees has had, as a status at the moment, has had the, is kind of the least declined. But obviously we have had a jump, as I've said, of 5% on the previous, on the pre-COVID figures there. So I guess there's a lot of factors in the data there, and it's, and I guess, statistics you can cut in various ways. But I think it is important, the standout point with these inspections is that we have been focusing very much on risk. The second point that you asked was about staffing and about. Sorry, go on.
Can I just come in a minute?
Yeah.
So the only thing I would say is that it's still suggesting that about a fifth are inadequate, and I'm just, wondering what the range of reasons for that are. Because that's still a lot. That's, you know, a fifth is quite a large chunk.
So this slide is actually indicating the decline in rating. So where you've got the red there on this slide, it is the decline in rating. So that might be from, you know, good to requires improvement, or requires improvement to inadequate. This slide is about this reflects the amount of inadequate. So we've got 1.1 presently. Does that clarify it? Sorry, I know it's a bit confusing the way the graphs are with the colours.
Yeah, it's just that I was looking at the 23.9.
Oh, sorry, you
requiring improvement.
Hang on. Yes, sorry. Yeah. So less than, you know, obviously not, you know, not good, not what we would not what we would want for our relatives or ourselves in terms of care. Yes, absolutely. I think the other thing to say again is that some of those services that are rated requires improvement in this in this snapshot would have been ones that we haven't been able to get out to that actually might have improved, because we do have providers who are challenging us at the moment on our approach, because we're focusing on risk, which means that if I've got a risky location that we need to prioritize in the Kirklees patch, I'm not then going to put that behind a service where they might tell us, actually, look, we think we're good now. We're still showing requires improvement. We've got to good in terms of our evaluation, you know, from the provider's perspective, and that's an issue at the moment. So there are services that we haven't been able to get out to purely because we're prioritizing risk, and you know, because of the way that we've inspected, you know, through there hasn't been the footfall in homes. So there's been through the pandemic, and so there's been a lot of risk that has, you know, sort of accumulated really, and that's why, you know, just like every other, you know, public sector, it's, you know, COVID-19 is kind of, you know, causing backlog of pressures. So I think that's an important context as well to understand, but not denying that, you know, we need to continue to be cited on, you know, how we can encourage, you know, providers to make sure and force through the appropriate enforcement action, force providers to make sure they're delivering good care. And I should say as well that this is a conversation that's ongoing internally between the Department of Health and Social Care, ourselves and providers, about how we can negotiate freeing up capacity at this time to be able to go out and inspect those requires improvement services that actually are saying that they think they've improved.
Thank you.
There was a second question, sorry, and I don't mean to take up lots of time, but I just want to answer the second question if I can, sort of succinctly, and that's to say that, so staffing, when we talk about staffing, we talk about, so what I know about staffing is in the adult social care sector, so we're talking about care homes, domiciliary care, etc. Providers pay, you know, providers set their own margins on pay according to the market, but we know that, you know, it's still not an attractive, you know, proposition for lots of people, particularly when the job market, there are other jobs, you know, it's actually there's a worker shortage in a range of, you know, different sectors for a whole heap of reasons, and we do recognize as a regulator through that's why I mentioned the state of care report, because it's very loud and clear about the staffing problems, particularly in adult social care, that have been prevalent, and the need for that to be addressed. And that is, you know, those conversations are still taking place at a high level in government at the moment about what can be done. I think there are various recruitment campaigns that CQC's got behind to really try and elevate the status of care work, which we know is absolutely undervalued for such critical, complex, difficult work that people undertake. So it's an ongoing agenda for us, to make sure that we're not letting it fall off the agenda, basically, with government.
Thank you.
Okay, thank you. But it's just this situation where you can get more per hour working in a restaurant, or even taking someone's dog for a walk, than looking after. And until we get a grasp of this nationally, not just here, I can't see how it's going to go away. So
No,
it needs
you're
loud
absolutely
voices, I think.
Yes, and if you have a chance to read the State of Care report, because we are not we're an arm's length government body, but obviously what we do is we want to be able to use our power and influence to make sure that these things that affect quality are absolutely front and central to the government, really, in understanding what the agenda is in adult social care and across the health and social care system. And so the State of Care report is really that independent voice that we have as a regulator to say, look, this is what we're finding. This is a precariousness in the sector. And this affects the whole system. So that's the importance about the State of Care report, that it talks about the entire system and about how if one piece fails, it all fails. And what is probably, I think, dawning on the government and on the public now is that adult social care is a really important part of all of that. And obviously the funding arrangements that government have just, put through about increased, monies for adult social care is, again, that's another important step, isn't it? But it's further down the line, and obviously there's a crisis now.
Thank you. Peter, sorry, you've had your hand up for a while.
That's okay, Chair. That's okay. Helen, you've got this facility in your organisation to convert a lot of qualitative judgments into numbers and produce graphs with them. And we all know you don't have to be a member of the Royal Statistical Society to know that that's fraught with difficulty. But I wondered if some of these poor performance figures in Kirklees, and you've just raised this question yourself, in talking to somebody, one of my other colleagues earlier on. I wonder if these poor ratings are somehow being dragged down by the elective care backlog in this part of the world, and by GPs who just don't pull the weight. So is the hospital service and our GPs who are not terribly interested in all of this, are they actually are they manifest in these figures at all?
So I need to clarify again that and apologies, I maybe didn't make this clear enough in my introduction, that I am the manager of adult social care.
Sorry, Helen. General practice looks after the health of people in adult social care, as far as I know. That
you're right. But yes, sorry. Okay, but it's really interesting your point about dragging down the ratings because of poor care in terms of what might be GPs and less flexibility, responsiveness of the GP service into the care home. But actually we wouldn't, if there was a problem with that, we would lay that at the door and actually talk to our colleagues, indeed Jill and her colleagues about any problem.
We'll save it for Jill. Thank you.
Yeah, because actually what we do is we look at the service itself, that's registered, and that provider, because clearly any failings in the GP, it would be unfair to lump in the adult social, in the care.
Well, I mean, you're raising a very critical question here about how are you going to possibly assess joined up care in a better integrated health service if you're going in there and you can't make a judgment.
We are working on, so this is part of our strategy over the next 5 years, is to develop the machinery, the staffing teams and the methodology that supports that exact issue. but at the moment it's not there. So the ratings as they stand at the moment aren't a reflection about any join up. They are individual location ratings. Yeah.
Okay, thank you, Chair.
Thank you. Thank you, Helen, for that. If we can move on to Joe.
Thank you.
And Joe, can I ask you limit your presentation to 5 minutes and then give the opportunity to members to ask you questions?
Yeah, that's fine. I'm Jo Walkenshawn, the Inspection Manager for Mental Health and Community Health Services in West Yorkshire. So I'll just pick up the key points in my presentation. So in the state of, this is just a bit of context in terms of that national overview, but that will just kind of set the scene a bit. The impact of the pandemic on people's mental health is well recognised, and the Centre of Mental Health has estimated that up to 10 million people, including 1.5 million children, are likely to need new or additional mental health support as a direct result of the crisis. So we've seen a real impact on people's mental health during the pandemic. Through our own feedback on care service, between April and December 2020, we heard that when some people sought help for their mental health from primary care services, they reported issues including feeling ignored by their GP or not having their symptoms taken seriously. People with mental health needs also felt that they could not get a referral to specialists from their GP because of lack of capacity in community mental health services. So these are the things that we were seeing during the pandemic. Our own inspection teams have raised concerns about people being admitted to mental health services with more severe mental health. They have also told us that people presenting in emergency departments and acute trusts struggling to find appropriate places for them due to lack of suitable provision. And we're also hearing that from providers, not just from our teams. As with other areas of healthcare, we saw that an increased use of digital technology has had a positive impact on some people. This has included online mental health wellbeing apps, video calling, which was definitely beneficial for some of our patients that have got quite chaotic lifestyles and have found it difficult in the past to keep to scheduled appointments. However, we do recognise that the use of digital technology was only accessible and suitable for some people. So that's just a little bit of the national context of what's been going on during the pandemic. For the next slides, I've just kind of covered the different services in Kirklees. So I won't go through every slide, as I know we're trying to keep my time down. But I'll just I'll just pull some key points. So for Locala, which covers, it's a social enterprise that has some community healthcare services for people in Kirklees, Calderdale and Bradford. When we last inspected Locala, it was November 2019, and we published a report in 2020, and the overall rating for Locala was good. We have no current concerns regarding Locala. We have a good working relationship with the senior leadership team, and they are really responsive to us. During the COVID-19 pandemic, Locala engaged in one of our transitional monitoring calls, which Helen touched on earlier in her presentation. During that call, we was able to gain assurance regarding the quality of care that they were able to offer, and we didn't have any major concerns highlighted. Oh, sorry, I've just jumped. We also have Swift in the Kirklees area. In their inpatient service, which is Enfield Down in Home Firth, it's a long stay rehabilitation mental health ward for working age adults, and we last inspected them in 2017, which was quite some time ago, but they did have a good rating. The reason we've not been back to them is because, again, like what Helen described earlier, during the pandemic, we've only been doing risk-based assessments and we've inspections, and we've not had any concerns raised around this particular location. Swift also have community-based mental health services for older people in Kirklees. The last inspection for community services for older people received a good rating, and again, no major concerns raised. We have community mental health services for working age adults in Kirklees, and at the last inspection they also rated as good. I would just kind of add on to there that we have had a number of suicides within that team, and themes from serious incidents included issues relating to kind of care plans and risk assessments not being up to date. So that is a concern that we have at the moment for the community mental health teams, and we are discussing this regularly at engagement with the Trust, and the Trust do have plans in place to improve things. The mental health crisis service and health-based place of safety in Kirklees rated good at our last inspection. The specialist community mental health service for children and young people in Kirklees, again, we last inspected that, I think it was 2019. It requires improvement. However, we've got no current major concerns around that service. And the community mental health services for people with learning disabilities and autism was rated good at our last inspection with no current concerns. We also have the Priory Dewsbury in Kirklees. It's a specialist inpatient service for adults and older age males with severe and enduring mental health conditions, and they may also have an undiagnosed memory-related illness. The service was last inspected in 2020 and was rated requires improvement overall. We did have a Mental Health Act reviewer complete a remote visit in March 2021 and in August 2021, and there was no major concerns found during that time. We did, however, in April 2021 have some serious concerns raised by the CCG with regards to Priory Dewsbury, and those concerns related to falls risk assessments which weren't in place, and some notifications of serious injury not being sent to the CQC. We've currently got this service on our local risk register due to these issues, and we are on monthly engagement with them. We inspected Priory Dewsbury in October 2021 and rated it requires improvement. We have Chart Kirklees in the Kirklees area, which is a substance misuse service for around 4,000 clients a year in the area. The location is currently unrated as it's a new location, but it was rated requires improvement at their previous location during our inspection in November 2018. We did complete a transitional monitoring call with the provider in January 2021, and no regulatory action was required following that call. The service had systems and processes in place to monitor safety and effectiveness and to ensure care and treatment was caring and responsive to individual needs.
Jo, can we look to move on a bit quicker, please? I did say 5 minutes.
Yeah, it's okay. I've got 2 slides left, and it was just finally to say that the service at Kirklees did report an increase to demand during the COVID-19 pandemic, during the height of it. And engagement meetings take place between CQC and the registered manager there every 3 months. We've got no current concerns. And I'll leave it there.
Thank you. Thank you. Can I invite members to ask questions? Dave Rigby, would you like to go first?
It's a question on, it's page 55 of our report, page 17 of your report, and it's reference there to people with more severe mental ill health. And there's a comment about problems finding appropriate places because of a lack of suitable provision. And I just wonder what that lack was. Is this a lack of appropriate inpatient beds or a lack of available staffing or a combination?
So what we found during the pandemic is that the acuity of the patients has been a lot more severe than what it normally is, and this has had an impact on inpatient units and in the community. So so both services have had a lot more very unwell people accessing them than normal, which had a knock-on effect and meant that those suitable placements haven't been as available as what they would normally be.
Okay, has that meant more out of area placements?
We haven't particularly seen more out of area patients placements than we normally do within Swift, which would cover your area. They do have out of area placements, but I can't see that that's been particularly greater during this time than it normally is.
Right, so in terms of coping with the increase, does that mean that patients have had to wait longer to get access to either inpatient or community services?
Yeah, it's meant that people have had to wait longer in community services, and it's meant that we've had to work differently with people in community services. So that has meant using the technology that we described earlier. So they've been doing a lot more calls with people, more virtual appointments, so that they could try and see more people.
And is that difficulty continuing? Is it still an issue?
I think it's improved, but it's not ideal.
Okay, thank you.
Thank you. Councillor Warner, would you like to ask your question?
Yeah, it's just a quick question regarding on the CAMS. You mentioned that there's, no current concerns raised, except I don't know what you call it when there's a 2-year waiting list and young people cannot get to see anyone. And if that isn't a concern, I don't know, maybe that's not under your brief, but it's one thing that really, is a concern, I would have thought.
Yeah, absolutely. So the waiting list was something we picked up at our last inspection of the CAMS service. So we are aware that there is a long wait to be seen. I suppose what I was alluding to was no new current concerns over the kind of COVID pandemic height, but the waiting list is up for CAMS services is a concern nationally. I suppose not just in this area. What we have got is I think it's called the Red Kite facility, which will be opening in Leeds soon for CAMS inpatients, and that will be covering patients from your area as well as in Leeds. So we're very optimistic about that.
Thank you.
But keeping up to date is still going to be very, very difficult, because we know in our ward alone, we financed help for 90 students, and we definitely need 100,000 quickly, because otherwise all those kids are going to lose their support. and they still need it. So it is, you know, the mental health of young people,
Yeah,
I think is a really needs flagging up.
Absolutely.
It is. It's definitely up on the agenda in terms of waiting lists and young people accessing treatment. And like I say, it is a national issue. It isn't just related to this area, and it's definitely on the agenda and being discussed on a regular basis.
Thank you, David. Are you wanting to come back in?
Yes, please. Yeah, got a question on it's page 61 of our report, page 23 of your report, and that's you mentioned when you were going through about the number of suicides. I think it relates to the South Kirklees area, as far as I can see from the report. And you say that this is being discussed with the trust. I just wondered whether any particular areas of concern have emerged where action needs to be taken to try and take some preventative action for the future.
So with regards to the suicides in those community teams, we've found when we've gone and looked into those, the kind of learning points, I suppose, were around the risk assessments and the care plans. So they're the things that we've been focusing on with the trust during our engagement, and they are working, you know, they've got working plans in place to try and improve their practices within those services around those areas. But SWIFT have quite in-depth learning from deaths processes and procedures in place, and they really do work hard to try and improve things in that area.
Thank you.
Thank you. Can we now move on to Jill?
Yeah. Hi, my
Jill.
name's Jill Taylor. I'm a
Can you
PMS.
please restrict your time into 5 minutes
Yes,
for your
I'll
presentation?
make it brief, Chair. Sorry. I'm a PMS inspector with West Yorkshire team. Specifically, I'm the inspector for GP practices in the Kirklees CCG, which is North Kirklees and Greater Huddersfield. I'm going to pick up the access question as well, which was asked earlier. So at the start of the pandemic, we know that GPs had to change the way that they delivered primary care. Use of existing technology to deliver remote consultations accelerated. And as a result, I think what we're now seeing is what we could call a blended approach to delivering services, which is a mix of traditional face-to-face consultations, telephone consultations, text messages and video consultations. I've only got 6 slides and they show a picture of where we are, but I think I really wanted to pick up the access question. So what is the current picture? So right now, what we're seeing is access to general practice continues to present issues. That's just not locally in West Yorkshire, but it's a national picture. As you're probably aware, NHS England and the Department of Health and Social Care published a plan in October 2021, setting out how they were going to support practices to improve access. And in our conversations with the CCG, we also know that they're working with practices on access. So as a regulator, we've seen a dramatic increase in the volume of queries and concerns from patients around access. So at the moment, to support an understanding of this in relation to the challenges, we've just this week commenced some very short inspections of practices with a specific focus on access. So in these inspections, we'll be looking at key issues like, can people access appointments in a way that meets their needs? Are there systems in place to support patients who maybe face communication barriers to access treatment? And importantly, do people with the most urgent needs have their care and treatment prioritised? Hopefully, these inspections will provide a picture of what access looks like, again, not just locally here in West Yorkshire, but a national picture. And then that can feed into the report and the guide and the help that the government and NHSE has disseminated. So I was just going to leave it there because I know we're short of time and I know there was questions regarding access. So happy to try and answer them or send them on to my manager who did the slides for the presentation.
Thank you for that. Peter, would you like to ask your question?
Thank you, Chair. Thank you, Jill. If we could come back to access, please, because
Yeah.
I raised it earlier, and what I wondered was, I was very interested in your new strategy and the outcomes, which it's on our page 37, your page 21, and one of your ambitions under number 11 down there is that you're going to take a big interest in joined up care. Well, that's what your paperwork says.
Yeah, that's our new strategy, Peter.
Sorry?
That's our new strategy with the whole patient journey. Yeah.
Yes, yeah. Well, joined up care is pretty fundamental to the way we're going, I think, in integrated care networks and so on. And I wondered, before we get on to access specifically, given that most doctors, GPs, are independent contractors, can this ever work? Because most of them only work very part-time, and most of them like to clock off at the earliest possible time. As we know, you've alluded to it yourself. You can get an audience with Pope Francis quicker than you can see a GP in some parts of the country. And I just wondered, can this ever work while they're independent contractors?
Well, I think, Peter, first of all, I'd like to say that what we see on the ground is, I think during the pandemic, GPs have worked extremely hard to provide care in a different way. And also, I think they've helped tremendously with delivering the vaccine programme. I think everybody feels that the only way that healthcare can work is with an integrated approach. I appreciate what you say, that they're independent contractors, and we've seen a lot of retirements, and we know we're having problems with GP retention, etc. But obviously our strategy lays out the integrated working. So we have to be hopeful that this will work and give a better patient journey for patients who are in need of the care. I mean, I'm not a strategist and I haven't written the strategy. I'm on the ground, I'm on the coal face, going out to GP practice. So it's very difficult for me, Peter, to give an answer to that, of what my position is. But those are my thoughts.
Yes, but I mean, surely if these people were incentivised yet more, they would do what they have done with immunisation. They've been incentivised and they've risen to the challenge magnificently. We've got to agree. Should they not be incentivised to work with other people in the future?
Well, yeah, and I think this is what we're seeing with access, with the incentives, and this is part of the plan that I alluded to earlier, for resilience fundings and incentives to move access along. But as I say, I can't really comment on the strategy. But yes, I understand what you're saying there, that incentives always drive improvement. Yeah. And there are plenty within the primary care setting.
And just to try, just finally, please, Jill, to try and clear up the question that Helen couldn't answer, is it likely that this elective care backlog and the epidemiologicals we've now got of excess deaths due to non-COVID causes, could this be dragging down the ratings in care homes? That inefficient primary and secondary care services are actually dragging the poor care home staff down the league table.
What we see at the moment in primary care is there are actually incentives to work with care homes. So doing home visits, doing ward rounds. So there is actually focus on GPs supporting care homes more. I mean, obviously the picture that we're showing at the moment of ratings is all we've been doing during the pandemic is rating risk. So the things that we've found recently come out of a risk background. So I don't think that will be a true picture until we move through this and we're routinely looking at other services. But certainly talking about incentives, there's the care home incentive, and GPs are working with care homes. I mean, I don't work with ASC at the moment, so I don't know if ASC have anything to add to that, of how they feel GP practices are interacting with their care homes. But certainly on the ground, we're seeing that they're doing ward rounds, that there's regular liaison. And when we do inspections, we liaise with the care homes to ensure that they feel that they're getting the appropriate support from the GP practices.
I mean, just in answer to your point there, Jill, we are seeing pockets where, you know, GPs are needing, you know, a bit of a prod to engage really proactively.
Sorry,
where care
that's
homes,
what I was after. Thank you.
Yeah.
Needing a prod.
so they,
yeah.
we we share that information with our colleagues where we've got concerns. So yes, that there are, but they are infrequent. You know, they are infrequent issues. Generally, GPs are the mainstay actually of ensuring that people are getting referred on as required, and providing a lot of support and guidance to care homes and care home staff. So yeah.
Thank you, Chair. Thank you.
Thank you. Thank you very much for that, Helen, and the team for attending this afternoon and providing the panel an insight into the work that your services have been delivering. I would like to recommend that the panel receives the information that's been presented to us this afternoon, and also if we can arrange a future follow-up session to include dentistry and look at the progress of the new strategy. If we can do that, that'd be much appreciated.
Thanks. I've also made a note about the insight reports that I'll share the links with Richard, and he can cascade that on then.
Thank you. Thank you for that, Helen. Okay, and that if we can move on to the next item, item 7, which is the bed remodelling report.
So we'll leave the meeting at this point.
Okay.
Thanks all for the invite. Thank you.
everybody.
Bye. Bye.
Thank you. Bye.
Okay, so the purpose of this report is to consider the proposals to reconfigure the dementia and intermediate care beds across Moorlands, Grange, Castle Grange, Ingsgrove House and Claremont House to include a temporary decant of the Homestead Day service. So if I can ask 1 second, Saf to introduce himself and present the report, please.
Thank you, Chair, and thank you, panel members, for allocating time on the agenda this afternoon for this item. I'm Saf Bhuta. I'm a head of service in adult social care. I'm here today with my colleague Helen Duke. Helen, do you want to say hello?
Hi everyone, I think we met last month, didn't we? So it's Helen Duke, Locala, Operations Manager.
Thank you, Helen. And I'm also here today with Diane Loftus. Diane, do you want to say hello?
Hello, I'm Diane Loftus. I'm a project manager supporting with the work that Steph and Helen are doing.
Great stuff, thank you. Chair, with your permission, I know we've shared the report and additional slides with the panel, and I'm assuming that panel members have had the opportunity to read through all of that.
They have,
but with
yes.
with your permission, Chair, I'd just like to open up a very scaled down version of the presentation with less than a handful of slides, just to build a bit of context before we go into the discussion and any questions.
That's fine, yes.
Okay, great stuff. Now, I might be at risk of breaking my system at this point. My laptop is infamous for throwing me out whenever I share a screen, but I'm going to give it a go. Can you all see what's on my screen?
Yes.
Thank you. Yes.
Great stuff. I'll put it in slideshow. Fantastic. So thank you again, panel members. I know I had the opportunity to do a briefing with Councillor Zaman where I went through some of the proposed improvements that Helen and I are presenting here today, but I just wanted the opportunity just to preface the actual discussions and questions with a bit of an overview, and just reiterate that really intermediate care in Kirklees is not a new idea, and rather the approach to home first and the ambition to shift care away from acute settings has been a shared objective for many years, and is reflected in the vision for adult social care. I wanted to also say that in the early stages of the pandemic, the collective response across the partnership, across the council, Locala and our acute hospitals very much prioritised speed over elegance in meeting national requirements for home first and discharge to assess. And this was helpful to some extent because it helped historical challenges or historical system challenges around formally integrated structures. They were mitigated through national emergency funding, for instance, and there was a system-wide desire and real energy for collaboration as a health and care system, and we made significant progress in a very short space of time. However, over the last 14 months, we've taken time as a system to step back and just reflect again on our overarching principles, our vision and our strategy. And we recognise that the closer alignment across the council, with Locala, with our acute trust partners, has helped us focus more on function over form. It's helped us focus a lot more on culture and behaviours that facilitate discharge decisions in the right settings, and just assure ourselves that service users or people navigate through the right pathways and through the work of the KILT programme, the Kirklees Independent Living Team, we have the opportunity to maximise people's independence. So I hope that the report and the additional slides gave panel members a bit of a flavour and an overview of what we're looking to do, and also gave you an overview of the actual KILT approach, which is a KILT partnership, and that's our approach for one single pathway for short-term intermediate care, which includes services from crisis response right through to bed-based models of support. And the proposals we're presenting today focus on the improvements to the bed-based model and the opportunities that that would present to the health and care system. Helen, do you want to take over?
Thank you, Saf. Yes. So what we've done today, I might just mute you, Saf. You've got some background noise. There we go. What we've done today, this is just a bit of a timeline, and we started our journey sort of summer last year and looking at how we can really improve our intermediate care service offer, both within a bed-based and community. And we had a look at what capacity and demand was across the system. So from that, we presented some findings and some modelling through our KILT board and our Care Close to Home contract that we have with the CCG in September, and had an agreement that what we would do is do some more work on this and have a look at how we can really improve what our service offer is to those individuals who are at risk of going into hospital, who have some therapy need, and those who are coming out of hospital, so we can try and avoid any delay with that individual's care. So that went through in March and then through to May, through a number of different processes and internal governance systems, looking at the quality of the services, looking at what the impact might be, looking at equality across the system, and to have a true approach across for all our patients who need to access this service. So through the summer this year, we've had the model presented at contract board. We've done our colleague engagement, which has been really positive. All the colleagues have been part of looking at what's not working well, how we can improve. We've worked with our current service users who won't be here when we need to implement the new model, because they will have finished their care with us. But what their experience has been, what's kind of prevented them from going home, and what they found different within a bed-based model, and that's been quite useful. And we've worked with our key stakeholders in primary care, other care homes, and within the secondary care sector as well. And then that consultation process ended last month, and then we've hosted some portfolio briefing, was approved when we presented that on the 18th of October. And then we've been through, we're at the panel today, and I know we briefly mentioned it in our Locala update last month. And we're looking at having our phased approach commencing this month, so we can sort of respond to those winter pressures and ensure that patients aren't stuck in hospital when they don't need to be, and we can support them in the right setting. Next slide, please, Saf. So our intermediate care service offer, so what our aim is to have a good service model is to have a flexible approach to service locations. We want to be able to offer the right care within the right setting to meet individual needs. And we want it to be an integrated approach. So we want to be able to move to a model where we can work more in partnership with the local authority and share some of those roles and responsibilities. Within the national agenda, Home First is the preferred model of care. So we want to move away from that reliance on a beds-based solution, because it's proven that patients who are supported within their home environment make a speedier recovery. So we want to make sure we're just prioritising the beds for those that truly need and can't go home at that time. And it'll also complement other services. So we've got our rapid response services in there. We've got our discharge to assess, which is our hospital transfer, our reablement and enhanced. So what the model will consist of is having a core main service offering a 1-bed unit at Ingsgrove House. And we thought that's the best location because it's on the border of North and South Kirklees, and it's got some really good transport links across the system from train and bus routes as well. But also access to additional beds at Moorland, so they've still got that ability to support patients across the patch. We'd be looking at an improved integrated health and social care model, looking at making sure there's best practice existing at both sites, but mainly at Ings will have that more, for those that have got that more acute need, we will be able to have an increased nursing presence so we can really support them through that intense care and then get them home more quickly so we can continue to support them in their environment. We'll be looking at a flexible therapy team by doing this, so we'll be able to have individuals supported by their physio or OT, and we're going to look at having some additional resource from the reconfiguration to get like a dietitian, have speech and language therapy input that can really have that holistic approach that'll in reach, but also follow that individual home so they're not starting that new relationship where we don't feel that they'll be able to do that. And then we'll have this single CQC registered manager approach as well, and that single team leader. Next slide, please, Saf. So this is just kind of a summary of what we're looking at. So the current model, we've got Ings and Moorlands, which we've got 30 intermediate care beds within each. And then there's 10 transitional at Moorlands and then a 7 plus 3 flexible beds within Ings. And we're moving towards then a 40 truly integrated intermediate care unit at Ings with still some support for additional 10 beds, a wing over at Moorlands, which means as well we can move to have that a transfer of dementia respite in that setting. And then we can have 20 transitional flexible approach. So that'll fit within the discharge to assess modelling, where we need to get someone out of hospital quickly into a setting, or where those that aren't quite ready to go home, they can move to that status. From a Castle Grange perspective, we've got the current model is 30 long-term dementia beds and 10 dementia respites. And then we'd be looking to make that change for 30 long-term dementia and then have them 10 beds from the Homestead Day services transferred from there. And then you can see Claremont there is looking at having a very similar approach and then looking to move towards a 40 long-term bed model in the future, sort of in the next couple of years. I think that's it. Saf, is another slide there? I think that's it. So thank you. Yeah.
Thank you for that. If we can move on to panel questions. Dave?
Yeah. Yes, thanks for the presentation. I was going to focus on the last slide you looked at, the summary of the reconfiguration. I have a bit of a problem in that I don't fully understand the difference between intermediate care beds and transitional beds. When I look at the definitions, there's overlap between the two. And there's a series of questions I was going to ask as a result of that. One is, well, first of all, to explain that difference. Secondly, why these particular changes, because it's not very clear why these particular changes. Thirdly, what are the benefits to patients? And fourthly, there's a reference there to minimising disruption. And would it be the case that individual patients would have to move between homes, or would you wait until an appropriate time when individuals didn't have to move in that sort of way? Thank you.
Yeah. Shall I come in first? That's just around the intermediate care.
Yeah,
so our intermediate care offer is that 0 to 6 weeks therapy offer. So it's those individuals that need some level of therapy that could be done within that period of time, so that up to 6 weeks, to get them to a level of independence so they can then either move on with their everyday life or maybe transfer into a longer term care. Whereas the flexi beds, they're more, for example, if someone's finished their intermediate care, at the minute they would move into a flexible bed if their package of care is not quite ready, or they may have, for example, a housing need, so they may not have another location to go on to, or they might be delaying some equipment coming along, so it could be that they're waiting for that equipment. So that's kind of the difference. And then moving forward for that more of a
can I just comment on that? What would be lost by just having a definition of transitional beds? Because it sounds to me like they're all transitional beds.
No, because with intermediate care, it is a service offer. So a transitional bed is somewhere, it's a kind of, I don't want to say it, but like a holding, it's sort of a next stage area, whereas there's not that need for a service offer within that setting. And then under the new modelling is a discharge to assess beds, but that'll be moving into next year. So those are people who are coming out of hospital more quickly, but they need maybe a further assessment, or the next destination is not ready. So that'll be a less amount of time. But from an intermediate care, that is an actual service offer.
Okay. I think it's an astute, just to follow up on what Helen said, it's an astute observation, Dave. I think what you'll see when you see the slides is that a lot of this is almost like a system that's based on a range of funding streams that have evolved over the years. So the transitional beds were essentially part of a funding opportunity through the acute trust, because we all recognise that waiting in a hospital bed doesn't deliver good outcomes for people. So shifting that care away from an acute setting, and we were successful as a system in bidding for some funding through our acute hospital trusts, and through that funding we developed the proposals around the transitional beds, which is if you're waiting for a provider of choice or you're waiting for a care package, let's not have you waiting in an acute hospital bed. Let's support you in waiting in a setting which feels more closer to home. But as Helen says, the intermediate care bed is a specific offer for more people with more complex needs.
Probably quite difficult for people to understand that difference. I can see why from a system point of view you use it, but on the ground it's a bit difficult to get your head around.
Absolutely, and this is why I think part of the proposals, because you asked earlier as part of the questions, why now, or why do you want to make the changes now, and what benefits? That is one of the factors that we're considering, that there are so many different funding streams that are used as part of the bed-based model, and it can be quite confusing, not just for the system, but for patients as well. So our proposal is that we want to move towards beds responding to actual patient needs. And rather than labelling them with different terms like transitional beds, or you might have heard colleagues talk about discharge to assess beds, we want to use a single term that describes a flexible bed-based offer that's pertinent to service user or patient need. And the funding will just follow then.
And I think looking at the benefits for our patients at the moment, so doing the work, I mean, it has been ongoing for the past 18 months now, and then looking at there's too many beds for what we need in the system, so we're averaging under sort of about 48 on average for the two settings, with an extra 3 at Newsom for those that need 24-hour care. So for the patients, it would be better to put that resource into the community so we can support patients. I mean, there is sometimes a waiting list into adult therapies, so this is allow us to support that individual so they don't decondition while they're waiting for the next step as well. And it will be with that person they're familiar with, the one who they've built the relationship up with, both the physio and OT. So it'll really help that smooth transition through and how the teams can work together to support the patient. And then the other thing was around sort of moving between. So if someone moves to transitional status, we wouldn't want to move them into another bed base. We wanted to try and provide all the care within that setting. And moving forward, that will help if they're in a flexible bed through that discharge to assess. They don't then have to move into an intermediate care bed. We can try and deliver their care. And this allows us to have that flexibility to deliver the care in that setting and then move home to avoid multiple moves around. So the status might change, but their location won't.
Thank you.
Thank you for that, Helen. Can I ask Peter to ask your question?
Thank you, Chair. I just wondered, I mean, like Dave, I struggle with this epistemological conundrum about what it is we're talking about, because and that's the one of definition really, and the way I sort of primitively worked it out in my mind, it's like a parking bay with a flexi ticket, where you won't get worse, and that's the important thing. I think that the point that you made. Forgotten what Alan's term was about people losing condition, deconditioning. Yeah, the important thing with elderly people, when you take over, you don't want them to get worse while they're with you. And I think that's, if we can do that, that's absolutely wonderful. I just wondered where the source of referrals was. I think we know how the long-term dementia patients kind of have finished up with you, and we know that they'll be staying. Probably for the rest of their natural lives. But there's obviously another population who are not demented particularly. I mean, they're elderly, but and amnesic like us all. But they obviously, have got a different set of needs. And are they from acute hospitals by and large?
I think there's a mix, Peter. I think there's a mix of referrals from hospitals, and there's a mix also. There's quite a nice split between referrals from hospital and referrals from the community. Right. I think in the early stages of COVID, we saw that there was a real imbalance, and we saw perhaps more referrals coming from hospital, around 70%, and 30% community. But for us, I think it's looking to introduce a bit more of a rebalancing of that, so that there's an equivalent offer for, let's say, our primary care trust colleague or primary care colleagues in terms of GPs, making those referrals into these services.
Good, because that really helps something that Helen will have heard me banging about last time, and that's prevention of unnecessary admission to acute hospital. If somebody, in particular, when you say we've got some places that have got a bigger nursing presence, particularly when people are acutely ill, if you can stabilise them, and get the blood chemistry sorted out and the basic AP X-rays and get all the little things done that they need to keep them going, you can send them home. And we used to have GP beds in cottage hospitals in the old days. Is this kind of a resemblant thing? A GP can admit somebody to you?
Yeah, the GPs do referral into our rapid response team. So it's those that are at risk from that same day admission. So we'll deploy a team out of nurse or physios, do that assessment, and then we can get them what we call step up. So the step up to goes into this setting that they can have for that short period of time, or we can have people deploy. So we've got the carers rapid response. We can support people at home as well, so they don't necessarily have to come into that setting. And that's all part of that urgent community response. So in the community, we've got those advanced clinical practitioners, so we can stabilise people at home. Those that can't stay at home and don't need that acute trust will come into a bed base in the community, but those that need to go in, they could potentially go in with a quick turnaround and come out as well. So we've got our same day units. So the teams, this will work together for that urgent response and that admission avoidance.
Yeah. Well, and that's great because it's taking work off. It's taking a hell of a work off the acute sector. And as Saf said, the worst place to be is an acute hospital bed if you don't need to be there. Just one last thing, please. Demand will often exceed supply. How do you deal with it? Do you have other places to refer to?
Yeah. Sorry, go Saf.
Sorry, Helen. I was just going to say, I think again, Peter, it's a really good question. That I think for us, it's about reducing the reliance on a bed-based offer and increasing the offer and reliance on home-first solutions. So, for instance, Helen and Local are all over the kind of discharge to assess pathways, as we call them, and so we focus very much on what we call pathways 1, 2, and 3. So that's either supporting you home with some light touch support. It could be supporting you home, but with a care package, for instance, or it's a lot more complex and we support you in a more complex setting, and that could be a long-term residential nursing placement, for instance. But our focus is now very much shifting towards what we call pathway 0 and pathway 1. Pathway 0 for us is what's actually out there in terms of community-based assets, and what's around you in the community through voluntary sector, through a thriving third sector, that can assist your recovery and assist your pathway out of hospital to home, or to even prevent the admission into hospital. So a lot of what we're describing here is shifting that balance away from the currency of a bed, which we're all used to, and the acute trust is used to, but actually moving that currency into, actually there are different models of care in your community, in your home, that the system can support you with.
Yeah, and in fact, in practice, the last thing a lot of these elderly people need is a bed. They need to be sitting up.
Yeah,
Thank you very much. Thank you. Thank you,
absolutely.
Chair.
Thank you for that. Councillor Leslie Warner, would you like to ask your question?
Yeah, sorry, I'm just one of these people who has a bit of a bee in my bonnet about certain things, and one of them is I know Locala is a not-for-profit, and the staffs mostly, I understand, still are NHS staff. But what I was wondering, there's two questions really. One of them is about when I see that beds have been bought beds from the council at a subsidised rate. I just wondered if that indirectly is losing money to the NHS, because at the end of the day, Locala has, I say it's profit. It does give some community money to community, but it also pays directors. And I'm always wary when things are happening that are selling off NHS assets. So, I would appreciate some clarification on that. And the other thing is, as I'm also, I think I said a director earlier by mistake, and I should have said an non-executive governor for the trust. You're always hearing at board meetings about the bed blocking. So when you say we're trying to move away from that, is it actually going to mean that this is going to help release more beds in the hospital? Because, last time I heard, we still had nearly 70 beds being blocked that they wanted freeing up, but there was nowhere for them to go. And we are aware you work hard on it all the time, but so it's just reassurance I want, really. Thank you.
I can come in on that, Saf. So sort of on the first point from Locala, so what we're doing with those beds, we don't need the beds. We've shown that there's been an average of under 50 throughout the time. So what we want to do is reinvest that money into additional resource. So we're looking at getting additional ACPs, we're looking at getting additional OTs, physios, assistant practitioners, a dietitian within the community services. So instead of paying for a bed, we put in that in resource to be able to provide more care for patients. So that's what we wanted to do here. And from the discharge side of it, actually in Kirklees, we're really good at getting people out rapidly. And if you look at the transfer of care lists in comparison to Calderdale and Wakefield, when you see, for example, at Mid Yorks, it could be that there's 70 on the list, but 12 are for us. And out of that, you might have 6 for an intermediate care. So we are really good at getting people moved through. And where we do have, if there's, for example, an increased demand, I know Peter's mentioned about that increased demand there, we've got the opportunity to spot purchase. If we cannot get someone home for whatever reason, we can quickly spot purchase a bed within the community, get them in there, and we have an outreach team in the discharge now that can go out and do that therapy and nursing assessment and social care assessment to make sure that their needs are met during that interim time before they either move on to long-term care, move home. So we've still got that flexibility that this will bring to avoid people being stuck within a hospital. There are still cases where someone might get stuck within there because we need to try and get the right support offer there, but the majority, I'm confident in Kirklees, and we've engaged with our stakeholders, which are Mid Yorks and CHFT, and they're quite happy with this new approach and welcome. And Calderdale are looking at how they can adopt a similar model from our intermediate care. So I think it's quite good that we're being used as best practice. But our patients and service users are at the heart of every decision we make. We want to make that an easy pathway for them, and they shouldn't see themselves coming through going from one team to another. It should feel like a flow and the care continues, and that's what we're wanting to do.
Thank you very much. That's very reassuring.
Councillor Zaman, you're on mute.
Sorry, the officers have put me on mute. Councillor Smage, can I ask you to ask your question?
Thank you. I appreciate you speaking of a person-centred approach, and also that people do prefer to be in their own home and not in hospital for a long period of time. But you've talked about the service user and systems and packages of care, but nothing really on the impact on the reliance on unpaid or informal carers in all of this. And I just wondered how the council are assessing the impact of changes such as this on unpaid or informal carers. There was a NHS report in March of this year that, as part of its findings, concluded that carers can experience themselves poor health, both physical and mental health, and that they could have support needs as well, and that there's a lack of clear and robust evidence on how best to support people caring for older populations. So with the movement towards caring at home, how are the council and partners looking at how any services support everyone caring, as well as the service user, and how are the council ensuring that discharges to home are to a safe and warm environment, and how are you monitoring that there's no repeat admissions as a part of these changes, and what happens to somebody who doesn't have any family carers to help them with all of this? Because with the best will in the world, paid carers could go in 4 times a day or whatever, but it needs that informal structure as well very often. So in all of these changes, we don't really seem to see anything about unpaid or informal carers. In fact, I couldn't find those words in your report. So perhaps you can outline that. Thank you.
Yeah, thank you, Councillor Smage, for championing carers and the role that they play. I think it's a fair point that perhaps we hadn't reflected much on carers and the role that they play in the report itself. And we recognise that there's a lot more work that we need to do in terms of engaging with families and carers. But from the work that we have done, so Locala colleagues have done lots of engagement sessions with the people who are using our services in the intermediate care beds. Some of my teams have done a number of consultations and engagement sessions, almost like a friends and family type test with those families where they have loved ones in the dementia care beds. We have used a lot of that feedback and a lot of that insight to help us develop the proposals that we're presenting today. For instance, one example might be, there's a real unique personality across each of our care homes, and it's really important to people that the care homes or the establishments don't reflect a clinical acute type setting. They actually reflect a personality that evokes feelings of hope and optimism, and it doesn't feel clinical. So we've purposefully used that, and we're purposefully using things like we'll have heard colleagues talk about the dementia standards, for instance. So we're using things like best practice standards for design, best practice standards for actually what does a space like that look like, to help us develop what we're looking to develop in these facilities. We're also continuing, we have a sort of friends and family or a mom test type approach, particularly in the intermediate care beds. Patient feedback is really important, and that forms part of our kind of governance within the work that we do. So for instance, we have patient reported outcome measures that I know Helen will want to talk about. We have quality forums where we bring some of that insight and feedback, and we're always looking at that as opportunities for continual improvement. We do recognise we've got a role where we want to interface with the likes of Health Watch, because they've got a real fundamental role in terms of the voice of people who use these services, and yourselves as kind of elected members and the champions of community. But we are engaging with colleagues in services such as community partnerships, other commissioning services that look at contracts that we have with carer services, so that we can start to understand what role can carers proactively play, not reactively, because that's important, but we want to move into that proactive space before a crisis happens, before there's a carer breakdown, where these services can provide that wraparound support to families. Helen, is there anything you want to add to that from a Locala point of view?
Yeah, I think we've done quite a lot of work on carers and intermediate care. I think our team leader and project leader, Ings, are really passionate about this and have been linking in with sort of regional programmes around carer support. We include families and carers at all our admissions into the bed base and include them within that care. And as part of discharge, we do home visits before they go home and work with families around that. And then we look at what additional support's needed through if they move on to, for example, reablement, which is an additional 6 weeks of service, which will get carer input. Or we've got our enhanced reablement as well, so we can provide, for example, night sits there. So if we need that additional support for carers and families, we can provide that. We've also got a contract with Age UK that support that transition home for individuals from the intermediate care bed unit to make sure everything's set up and ready to go as part of that sort of additional support. And then as part of the Pathway Zero work, the local authorities work as part of the discharge hub of engage with the third sector. What more can we do to offer carers and our service users with that support that they need? For any urgent responses while they're around the repeat admissions, we're moving towards, for our urgent community response, self-referrals. So anybody who feels that they're in a crisis can contact, which you'll either get, it could be an advanced clinical practitioner, it could come through to a therapist or a nurse or even a carer to have that rapid response, and carers can access that as well. So they've got that, if it does go into crisis that we've not been able to support prior to, they can still avoid that admission and then also get that rapid support for their needs.
So how do people know about that urgent response, and how do carers, how are they supported when somebody is discharged home? How are they supported as well as the person who's being cared for in the longer term? Have you looked at the impacts of changes in relation to that, please? Thank you.
Yeah. Helen, do you want to take probably both the UCR and the discharge thing?
Yeah, so UCR's publicised widely, and GPs can refer in. So if a patient or carer rang to the GP, they can get access. Anybody who's accessed our services and who are in hospital, we have a discharge team in hospital that support everyone coming out on those pathways. We're just updating our literature, and as part of that, they will be able to access the urgent community response. For anybody that's not coming out on intermediate care and going home as part of the discharge to assess pathway, we have a team that do a bit of a check-in the next day just to see how things are going, anything they need. Carers are involved within that care plan set for when they come home, so we'll understand that front end before they're discharged from hospital or moved on from the intermediate care, what their needs are. So we include family and carers in all that planning, so at that stage we'll know what their needs are, and we'll be able to support them with whatever we can put in place to support that. And we would never send anybody home if they didn't feel safe to do so. We would try and provide that additional support.
Okay. All right. So you say you do a visit the next day. So how do you know before you discharge to home that people are okay going home, that the environment in the home is okay for them to go to, especially if they don't have any family members to talk to about that? Yeah.
If they're coming out of an intermediate care bed, we do an environment assessment. So we actually go home to the environment and we look at what equipment they might need. We look at what their care needs will be, and we'll do that as part. We'll get to know that on admission really to the bed base, because we're getting them to a stage of independence of what they'll need moving on. If they've got any additional housing support, we'll get that included. If there's going to be a social care need, again, that assessment's done as part of it, and we take that holistic approach. Like I say, within all those assessments, any families that are around we'll support. If there aren't any, it will be a social care need, and they'll do that assessment and we'll work together.
It's also worth adding, counsellor, that all of this is part of that multidisciplinary team approach. So it's not just one agency looking at it, in a silo. The service users, the patients, will be looked at through an MDT, and there's a collective sort of response to the package of support or the offer of support for these individuals.
Just to add as well, we're wanting to link in with the social prescribers, with the GPs that understand. So we're trying to include that as part of the pathway, and that's some of our improvement work that we're not particularly good at the moment, but we are including them, and we're looking at what is going to be available in the area that they could access that we wouldn't necessarily know about. So that's something we are working on at the moment.
Okay, thank you.
Thank you. Dave, you have your hand up.
Yes, thanks. Yeah, it's a question on one of the strategic drivers, so page 85, the second bullet point. In that paragraph, there's reference to quite a wide range of services within the overall service, and we've heard another one this afternoon, which is new to me anyway, which is Pathway Zero. Now, it's really about, I suppose, how is all that coordinated? How do you ensure there's a phrase in that first line of the second bullet point, integrated partnership, and would it perhaps be useful to have one kind of umbrella name under which all these services sat, so that from the point of view of communication you could say, yes, it's part of this service with an umbrella name?
Yeah, absolutely, Dave. I think we refer to it as the integrated health and social care services, and so all of the pathways sit within that framework or within that umbrella. Locala have the kind of national mandate in terms of understanding, monitoring, tracking the volumes that go through those pathways. And so, you know, we'll have colleagues or folks across the services which will coordinate, as we have discharge coordinators essentially, who will navigate people through the appropriate pathways. They will have those kind of joint discussions with other allied health professionals in terms of understanding what's the right pathway that this patient needs to navigate to. And then almost the receiving services are what we described earlier, such as the Kirklees Independent Living Team Partnership. So that's the kind of receiving pathway into all intermediate care services. And our focus very much will be about supporting people home. But yes, I mean, that we describe that as the integrated health and social care offer that feeds into the sort of KILT approach.
We have just developed a one discharge form to include that KILT work and all health services. So where we had a trust filling out maybe 5 different referral forms, because they might need maybe 4 health and a social care. So we brought that into one discharge form. And then our next stage, we're looking at how we can include the social care only element, which can then, what that comes into an area, we do a joint triage and then look at anyone with maybe complex needs with a number of different areas. We'll go to an MDT, we'll have a discussion, what's the best place for that individual, what are their needs. So luckily we've got that in place now, we're just improving that every day.
So in terms of staff involved in different elements of the service, the communication between them, is that kind of up to them on a reactive basis, or is there a kind of proactive element to this which ensures that actually takes place?
Both, Dave. I think initially, perhaps as we were sort of getting used to coming together and we were getting used to doing things very speedily, we had to test a number of different approaches out. So perhaps, you know, we were at risk of being reactive, but it was helpful because it allowed us to test things and sort of almost learn from them very quickly. And one of your questions earlier was, well, why now in terms of making these changes? It's because we tested a model very early on throughout the early stages of the pandemic, where essentially what we said was, you know, we're not really worried about funding streams. We're not worried about the designations of the beds. We're just going to call them all flexible beds, and we will respond to the bed-based offer based on people's actual needs and their conditions and what their choices are. And what we realized through that was that actually that worked really well. It took us quite a bit of time in terms of the startup and the investment in terms of procedures, processes, learning, development, etc. But when we got going, you know, it worked really well. And it was perhaps one of the standout models nationally, I would say, because there weren't many other areas who were doing that. Particularly, we did this before, or the Kirklees area did this before the notion of the CQC designated beds even came about, which were COVID designated beds. We were supporting COVID positive patients in a designated setting with the appropriate infection control arrangements. So for us, you know, all of that learning has led to where we are today, and all of that has helped us come together as an integrated system. So very few occasions, we will fall into bun fights about what Locala are doing, what the council's doing. We're quite mature now in terms of coming together strategically and operationally to understand what we need to do now, but equally think about the direction of travel.
Okay, thank you.
Welcome.
Thank you. Is there any further questions? Panel members? Okay. Well, thank you, Saf and Helen, for attending the panel this afternoon and presenting us with an overview of the fantastic work that you're delivering. What I would like to recommend is that if maybe sometime in the new year, early on in the new year, we can have some feedback on how maybe the winter pressures have affected some of the discussions that we've been undertaking this afternoon.
Yeah, I would welcome that.
Absolutely.
Chair.
Yeah.
Okay. Well, thank you. Thank you for attending.
Okay. Thank you for having us. See you all later.
Thanks.
Bye.
Thanks, panel members. Cheers.
You're welcome. Thank you.
Bye.
And if we can move on to the next agenda item, which is the work programme for 21 and 2022. And if I could ask Richard to take us through that. Hello, Richard.
Yeah, that's fine. Thank you for that. Yes. What I wanted to do, if we can, is focus on the outline agenda plan, which is page, it's the last one of the pack, page 109, because we're aware that there are obviously a number of areas that I know that members do want to sort of focus on in the coming months. But what I want to try and do, if possible, is to sort of focus down on some of the key issues, because some of the areas that we're looking at obviously cover a wide range of areas. And I think if you remember what we said we would try and do this year is we had a number of what I call themes. So some of the issues weren't necessarily one specific item, but came under an umbrella of themes. So just to confirm, as things stand, our next meeting, as you can see, is scheduled for the 9th of February. 2022. We've got 3 potential items on that agenda. One is definitely confirmed, which is the review of the primary care networks. And I know obviously there's been a lot of interest already highlighted around the role of GPs in terms of delivery of primary care services. So we will be looking at that. The other area that I know you have flagged is mental health and well-being. That's to be confirmed, because that's one of the areas, if possible, I'd like to sort of get some more of a steer in terms of some of the issues that members want to look at. And then finally, we're also looking at potentially some changes to the direct payments, which we're still waiting for confirmation on. So if I can just refer to the mental health and well-being theme, there are obviously quite a variety of areas that we have kind of identified under that theme. So, for example, one area which I know has been on the panel's agenda for a number of years is around suicide prevention, and that in itself is obviously quite a big area to cover. So I did circulate, hopefully all members got it, sort of like some areas of potential consideration if we were to include suicide prevention, which would include, for example, getting an update on the current position, including obviously an up-to-date analysis of the local need, and looking at things like the suicide audit or suicide profile. Looking at the impact that the Pathfinder support workers have had in their work, and that was something that was flagged at one of the previous meetings, and they provide device training and support for particularly for men who are vulnerable to self-harm and suicide. Another area that we had identified in a previous some previous work was the impact that the work that's been done on prevention and educational work, particularly in schools, and helping to reduce things like self-harm and suicide. And a final thing that potentially we could look at is an update of the work being taken by the council itself in supporting mental health health provision across the various localities in Kirklees, and underlying on all that, we're still mindful on the impact of the pandemic has had. So obviously we would look at that as well. So that's just one aspect of mental health and well-being. Another aspect, I think one of our co-optees, Lynn, who can't be here today, has highlighted her wish to maybe consider the wellbeing and support for unpaid and working carers. So again, that's something we could look at. There is some work being done by the West Yorkshire and Harrogate Health and Care Partnership. They have developed a 5-year plan, which they've called Caring for Carers. So, for example, we could potentially invite members from that partnership to the panel to maybe go through some of the work they're doing on that, and we can have a bit of an update and progress report on that. Young people's mental health and the services offered through CAMS is another area. The only thing I would highlight there is that there is some issues around that have been identified in the Children's Scrutiny Panel work programme. So they have already identified some aspects of that they will be looking at. So obviously I'm mindful that if we were to look at that, we don't want to obviously cross over and obviously duplicate any work that obviously that panel's doing. There's aspects around the transition from children to adult mental health services. There's a work that's been delivered through Kirklees Integrated Wellness Services, and of course, not to forget, there's all of the services provided by the South West Yorkshire Partnership Foundation Trusts, which we said we wanted to look at, which would include the redesign of their services, any post-pandemic new initiatives they're bringing forward, and obviously also to get a feel for how the trusts operational challenges and its recovery plans have progressed, obviously because of the pandemic. So I suppose what I'm trying to identify there is a massive amount of areas of work that we could concentrate on around that theme, and obviously it's impossible. We won't be able to cover everything in that one meeting. So if I can, Councillor Zaman, if I could, I would welcome members' feedback around that theme to see if there's anything that I've just gone through that they feel they would particularly want to focus on. Bearing in mind, we won't be able to obviously cover every aspect. Thank you.
Definitely.
Thank you.
Definitely. Dave, you have your hand up.
Yeah, I was going to just I appreciate there's a lot there, but also add that there were a number of issues relating to mental health services raised this afternoon by the CQC, one of which did relate to suicide issues, and one related to difficulties in providing for people with severe mental illness arising out of the pandemic. I think going back to Richard's point, that first bag of issues around mental health and well-being, and I think you also mentioned the pandemic effects as well. Perhaps that'll be something to focus on, because appreciate we can't focus on everything.
Yeah, definitely. Yep.
Okay, that's fine. Thank you, David. I've noted that.
Peter, would you like to ask your question?
Thank you, Chair. Yeah, I mean, Richard knows. I've sent Richard a little note about this with ideas that I felt that because of the overwhelming nature of the pandemic, you know, a lot of attention has probably been sort of drawn away from. I don't mean they've not been pursuing the main agenda, but I thought if we got both providers in, the South West Yorkshire Trust and the council, and really asked them to outline what the principal achievements have been. What were their principal performance indicators for the success or otherwise they've been having, and it'll be success because they don't tell us about anything else. And then if we could from that allow suicide and well-being and other things to be drawn in. Now, I mean, it probably needs enough time for us to be able to talk, and certainly the trust from memory, and Richard will forgive me if I'm being unkind. Most of the presenters from the trust have usually done a course to appear on Just a Minute, on Radio 4 and can really articulate their case for hours and hours and hours. And whether we get any questions in, of course, is another matter. But I thought if we condensed it to 2 providers and let the other things fall from it, and make sure we make a note to ask Kirklees providers for the recent data on incidence, prevalence, and what they're doing about prevention of suicide in the midst of it. It's an oversimplification, but I thought it might get the long list down to a minimum.
Well, we have had suicide in the past, haven't we, on the agenda, but it's just that this time we've not included it. But we can sort of look at it as part of mental health.
Yeah.
Councillor Warner, yeah. Is that okay, Richard?
Yeah, I've noted that. That's fine. Thank you.
Yeah, just following on what Peter's just said, I think getting the council to share how some of their monies has gone and the impact would be quite interesting. The reason I ask that is that ward councillors were allocated a fair sum of money for the previous year to be spent on mental health. And in Combe Valley, we made a decision that we wanted to be directly involved in the treatment of it, in securing a group called the Ladder Group, and they've been giving treatment. Now their money runs out in March, and it's where do we get more money to continue to support these young people? Because the council decided that actually the next tranche of money was going to active travel. But I do know that some councillors said that they just allocated that money to schools. They just thought the easiest way was to give it to schools. But when I've asked, have they shown how that's been used? And given that many of our schools are now, or most of our schools are academies, we don't actually know how that's actually been used. So I would be interested. I'm really, okay, I'm a bit careful because we're all concerned about everything. But with the young people, there's a lot more suicides. I mean, I used to live in Hebden Bridge. My daughter was up again last week to yet another suicide of a young person. The real cluster of young people just, So is there any reason why we couldn't have an extra meeting in January?
Richard?
The answer is we could do it potentially. We obviously would have to find a slot, and we'd have to be clear about what we would be doing with that extra meeting. But just going back to your point, Leslie, about the issues around young people in particular, because you've obviously highlighted that. And if you remember, I did mention that the children's panel have included that as a key area of focus on their work programme. So what may be something that might be useful, if you wish, is that we could liaise with colleagues who support the Children's Scrutiny panel to see if they've identified a date for when they are going to be covering that area of work, and perhaps we could ask if it was possible that maybe some members of this panel could join in on that conversation. So it sort of avoids any duplication, doesn't it, of work, but at the same time, obviously it enables members of this panel to have potentially some input into obviously what clearly is a very important area of work. So if you're happy with that, Councillor Warner, I'm happy. I'm more than happy to sort of liaise with colleagues who look after that panel. And we could see if we could get involved or help have some input into that area of work. We'd have to speak to the chair, the lead member of that panel, but I'm sure they would be sympathetic to our request.
Does children include up to 18? Do you know?
In terms of what? Sorry, you talk about mental health now. We're talking about the children. Yeah, that's partly why I put the one of the areas that was identified in when I was talking for there was a transition from children's to adult mental health services, because obviously there is that change, isn't there, when they come out of the sort of the children's area of responsibility into the adult. So we have identified that is something that we potentially that we do have a concern about. That transition period, Leslie. So, so I don't know whether the children's panel have actually got that on their list. I suspect not, because they will be very much focused on children, which I presume they would class as being under the age of 18, or it might even be 16. I would have to find out exactly what the cutoff point is for that. But certainly in terms of the issue around young people's mental health, and that's looking at things like the initiatives to solve the problems experienced by children, mental health provided by different teams and providers, particularly including the links to educational outcomes, family support, all that stuff, Leslie, we could potentially cover alongside the children's scrutiny panel, if you want me to liaise with them.
Yeah, absolutely. Can I just also add, just because of personal experience, it tends to be 16, because having a personal experience where one of my kids had a particular episode, shall we say, I was not allowed, it was confidential in terms of his mental health at 16.
Yes.
And yet when it came to an ambulance coming, there's this grey area of when you're allowed to be 16 and when you're allowed to be, and when so it is a grey area, I think.
Yes. Yeah. Okay. So what I've noted is that obviously there's some suggestions that's been put forward by both Dave and Peter in relation to some of the stuff that we could cover at the meeting in February. So what I'll do is I'll work something up, if that's okay, around those suggestions, and I'll circulate that to all members just to make sure that everyone is on board with that, and then we can take that forward, and that would probably involve, as Peter mentioned, bringing in maybe representatives from the South West Yorkshire Foundation Trust, obviously people from the council as well, and some of the issues that have been highlighted should fall out of that. And then Leslie, in terms of your aspect, I will liaise with the scrutiny panel for children's and see if there's any work they've got planned around young people's mental health, and we can maybe cover that off there as well. So that's helped for that one. The next big issue then, which we've got potentially earmarked for March, is the work of Kirklees Public Health. And again, that covers a broad range of areas. I've sort of summarised it into 3 key areas. One is in relation to the work that they're doing on population health management, and there's a number of areas that I highlighted that we could look at there. The second area is around looking at their overall performance of local immunisation programmes. Obviously, the big thing at the moment is obviously the vaccinations for COVID, but it's very important not to forget there are much wider immunisation programmes in play, and already I think I've already noted that there are some concerns, particularly for young children, that some of those immunisation programmes are being overlooked, because all of the focus is around COVID at the moment. So we could look at that. We could look at the local arrangements, the structures and responsibilities that are here locally. We could look at the performance of Kirklees against national standards.
And also the take up of them as well.
Absolutely, yeah, absolutely. We could cover all of that. And then the third area, which I think this was something that Peter, you highlighted, was just looking at the position in relation to excess death rates in Kirklees from non-COVID causes, because I think there is again a concern that because of all the focus that's going on to trying to deal with the pandemic, a lot of things have been overlooked in terms of a lot of the services, in terms of like cancer services, etc., have been under pressure. So it will be probably an area that we would look at to sort of just clarify what the trend is of non-COVID excess death rates, and that would be sort of pandemic versus pre-pandemic, if that makes sense. So we can just get a feel for that, and also look at the things like the age profile, look at the race, ethnicity, gender, cause of death, etc. So we've got a feel for if there's any particular community that's been impacted more than others, or a particular age group that's been more impacted than others. So that's another area that we could potentially look at.
Richard, I raised that purely. It wasn't that I'd had a bee in my bonnet about it. It was the National Audit Office actually who reported a little bit earlier this month, the very beginning of the month. They reported, and it's on the public record, that we've got an excess death rate now that will exceed 12 million by 2025. That's non-COVID deaths that excess means could have been avoided. So it's really about the thing I was banging on to them about this afternoon, about delayed referral and not getting seen quickly enough, and having to wait for your endoscopy and these sorts of things, where fairly straightforward tumours and operable things can be picked up early and in fact are being missed. So nobody's going to admit to it, and it's nobody's fault at the minute because everybody's up against the wall with the infection, and the Omicron thing will probably intensify the problem. But that was my reason for raising it.
Yeah. Okay.
Thank you.
So so again, I don't know if anyone else has any views, because I say there are 3 sort of potential areas there that each one would take up probably a full item at a meeting. So in summary, we've got the population health management, we've got the local immunisation programmes, and we've got the issue around excess deaths. I don't know if there's any particular area that members would particularly wish to focus on. I think to do all 3 would be a big ask.
Yeah, if there's areas where they could give us written sort of information, prior to the meeting, and then maybe we could ask them questions. They don't have to go into detail.
Okay.
On those items.
So, so do we have? So there's no. So do we have any strong views then, or do you want me just to sort of?
I think maybe a focus on the excess deaths issue. That seems to be pretty significant.
Okay. That's fine. And what I might do is the population health management includes looking closely at how public health and others use the data on physical health, mental health, and other social factors to help identify where resources are deployed, and that kind of partly links, I think, to the issues around excess death, doesn't it? So I mean, it might be able to weave that in somehow. And try and cover those 2 areas off if you think that will help. Peter's got a comment. You're on mute, Peter.
Apologies. It would have been better had it remained that way, probably. But I think that we've done well-being with the public health team, quite thoroughly over time, and I wouldn't want their take on public health to be steering us back to well-being the whole time. I think this comes because the team is the team is there in the formal sense. There's no doctor there, so I wouldn't want them to try and deflect us. But excess deaths are their business, and I think we should ask them about it. Thanks.
Okay. Right, I think that from my perspective, Councillor Zaman, that's covered everything that I wanted to highlight as part of the agenda plan. I don't know if there's anything else members want to comment on in terms of the wider work programme, but certainly in terms of the next couple of meetings, I think we've got more than enough on the schedule now, I think.
Yeah, I think so too. Is there any further comments anybody would like to make? Okay, well, in that case, it brings us to the end of the meeting today. Thank you to the panel members for attending, and the staff that have ensured the smooth running of the meeting, even though we've had some background noise today and some disturbances. As Richard alluded earlier, the next meeting is on the 9th of February 2022. I'd like to wish the panel members and officers a very nice and peaceful Christmas and a very happy new year. and see you on the 9th of February in 2022. Take care, everyone.
Yeah,
See you soon.
thank you, Chair. Thank you.
You're
Best
welcome.
wishes.